It is a great privilege and almost an unexpected experience to look out upon such a sea of faces. So that means that you're all osteopathically oriented. So I assume that you all treat babies. Is that right? Everybody treat babies? Well, if you don't already, I hope you will by the time this program is finished. The topic that we are talking about is that of extremely premature babies. 2 years ago, after I had conducted a course in Pescara in Italy, I received a request that I would go to the nursery at the hospital where they had a nursery for extremely premature babies.
Bitte keine Blitzlichter, weil
Please be so kind and don't use any flashes when taking photographs, because Dr. Frymann has a problem with her eyes and she won't be able to see if you use flashlight. Thank you very much.
That were about so big. I had no idea what one did with babies that small. That was one area that I don't think Dr. Sutherland particularly mentioned. And when I went over to the hospital, the neonatologist said, "You can do anything you want to." Well, that's a dangerous statement, you know. But what impressed me most was that going into this nursery, I noticed a silence which is not typical of a nursery for full-term babies. But this was a silent nursery. There were about 10 babies there. And also, too, another characteristic different from that of newborn babies was that there was no movement, a stillness of these babies in their cribs. And as I looked at them and observed the silence and the stillness, I thought, what would Dr. Sutherland say about these babies? And then I realized that as I was watching these children, what they needed most was a baptism of the breath of life. They needed that inspiration of the breath of life, with all the other functions that they would eventually need. That was the one thing they needed right now. And so that was where we began. I was there for just long enough to look at these 10 babies. And then a year later, I was again teaching in Pescara, and this time the neonatologist was somewhat curious as to what I might do to a baby. He didn't say anything, he just stood and looked. Because this was a strange experience for him. In fact, it was a strange experience for everybody else in that area. But these babies were particularly fortunate because the students at the Osteopathic College of Pescara would go to the hospital and give osteopathic treatment to these babies twice a week for so long as they were in the hospital. Now that was a wonderful opportunity, an opportunity for the students to become acquainted with such babies. So that is the sort of background upon which this particular talk was generated. My experience in Pescara with the extremely premature babies. So that's what I want you to translate your consciousness, not into a newborn baby, but into a tiny, tiny premature baby. And let's see what unfolds from there. We don't have another light, is that right? Not another focus light. Okay. Well, we'll hope to see all that I can see. There is no more serene and beautiful experience than to hear a mother, a new mother, hear the cry of her baby. And then to recognize that her period of hard work and diligent endeavor to deliver this baby is at last accomplished. And then to look into the eyes of this baby for the first time, the way the baby's intent of looking at those eyes, a wonderful experience. And then for mother to look into the eyes of that baby. And for every mother here who has delivered their first baby, I'm sure you can identify with that particular reaction on the part of the mother and on the part of the baby. Because that is a unique and wonderful experience. And then recognizing that the baby not only looks into the mother's eyes, but the next thing, the baby has the benefit of tasting for the very first time a very tasty meal which the mother provides in abundance. But perhaps mother notices something that's not quite as joyous a vision in front of her. She notes that perhaps the color of the skin of this child is not as good and as clear as she'd like to see it. It's got a little bluish tint to it. And perhaps it is not able to suck and hold the nipple effectively. And so he doesn't get that first wonderful meal. And then it is recognized that this little baby is not fully equipped to accomplish what is necessary at this stage in life. The respiratory apparatus of this baby is not functioning adequately. The baby's breathing is not adequate. And then noticing that the baby doesn't take hold of the nipple and suck effectively, because the digestive system of this baby isn't quite as good as it should be. And so then it is questioned, well, now just exactly what is the baby's age as it is related to the known date of conception? Or is this baby not a full-term baby, but a preterm baby? Ha ha ha, that's lovely. That's good, that's lovely, thank you. We're getting there. Okay. And so we recognize that this baby is a little small, or maybe very small, and has obvious impairment of respiration, is unable to process the nutrition which is available so readily from mother at this moment. And this baby is actually much younger than the full-term baby which was expected. We may not know exactly what the age is, but most of these babies that we were seeing in Pescara were between 23 to 26 weeks gestation. So you can see they were tiny babies with many problems to be overcome. The babies that were evaluated and treated there were babies that did not have any known pathology, such as a heart defect, a respiratory problem, or some other structural pathology in the body. They did not include children that had any anatomical discrepancies that might have occurred, because they wanted to have as close to a healthy baby, even though a small one, for their research studies. Okay. And so you begin to look at these babies to see what is their potential in life. Do we know what their potential in life is? In fact, we never know, do we, the exact potential of any baby. But we give them the benefit of the doubt. Okay. All the elements to give one an evaluation of this child were established. They have limitations, yes, but those were established. You know what I'm going to do? I'm going to ask somebody to read this for me.
An isolated target, oriented movement of the hand while the other body parts remain unchanged is not possible. The high redundancy of neurons and their connections, which is the neurobiological basis of the so-called generalized spontaneous movements and the lack of cooperation, challenges the neurological examination. All attempts to establish a standardized and ubiquitous accepted neurological examination in early infancy have failed so far. In everyday practice, the physicians try to overcome the gap by combining single items of different approaches to create a personal neurological examination protocol. All that these protocols have in common is that they focus on motor function, neglecting other important fields of the neurological examination, like self-regulation, interaction, attention, cognition, speech, communication, visual and acoustic function, as well as sensory function. Often, many details of the motor function, like passive and active muscle, passive and active range of movement, muscle reflexes and reactions, postural responses, and positions are documented, while a clinical reasoning of all signs and symptoms are omitted. Currently, there are some new trends to evaluate brain function in infants in a more reasonable and comprehensive way. A neurological examination has to answer 4 cardinal questions. Question number 1, is brain function intact or disturbed? Question number 2, if it is disturbed, which networks or systems are involved and how? Question number 3, are there signs for etiology? And question number 4 is, what will be the prognosis? A technique of Gestalt perception will be used. During the first 3 months, infants with intact brain function show fluent, complex, and variable generalized movement patterns. On the other hand, infants with disturbed brain function have abrupt, simple, and invariable generalized movement patterns. At the post-term age of 3 months, these generalized movements are highly predictive for motor development in the future. Number 2, to master these generalized movements, an intensive training is mandatory to be able to categorize the GM correctly. The GM was?
The general motor movements.
General motor movements correctly. Need to study typical videos. General intrauterine movements start at 8 weeks of gestational age and can be observed by ultrasound. They are governed by so-called central pattern generators, CPG, which seem to be subcortical but influenced by higher cortical function. GM are fluent, complex, and variable from the beginning. 3 different phases can be distinguished. Preterm pattern, between 8 to 36 weeks. Term pattern, called writhing pattern, at 36 to 10 weeks. And infant pattern, called fidgety pattern, from 9 to 18 weeks. Beyond that age, the GMs are increasingly overlapped and goal-oriented movements. Gestalt perception then relays, this is 5 or 22, this is 6, yes. Gestalt perception then relays months of life. It was thought that higher brain function is not yet at work, rather unspecific PET scan studies in newborns has now shown the opposite. Distinct optical, motor, sensory, and acoustic networks are already in function. However, clinical correlates are subtle and have to be interpreted with caution. Head growth curves suggest that brain maturation during the first year seem to be continuous. However, recent data now demonstrates that there are 2 developmental hotspots, one around the age of 3 months and the other around 9 months of age. Typical signs of differential neurological categories or systems such as self-regulation, interaction, attention, cognition, speech, communication, mimics and gestures, visual and acoustic function, sensory and motor function are defined. In the beginning, Dr. Ken Graham gave me the topic of the osteopathic approach to the first 2 months of life. It was to be a very practical pediatric course to emphasize the work of W.G. Sutherland, D.O. My first question was, what do you mean by the first 2 months of life? I had recently been invited to visit the NICU for extremely premature babies at the General Hospital in Pescara, Italy. I did not know what to expect, neither did I have any idea what Dr. Sutherland would do. I was first impressed by the silence of this ward, the stillness of these tiny babies. I waited and I watched. Then I began to recognize that the profound need of these babies, these infants, was a baptism by the breath of life. I gently placed the tips of my index fingers on the apophyses of the early developmenting temporal bones, providing a delicate stimulus of external rotation of the temporal bone, the resuscitation technique. Initially, I scarcely perceived motion, but I waited. Then a little hand moved, and then a little foot. Soon, I observed a significant increase in the excursion of the thoracic cage. I briefly placed my hands on 10 tiny babies, and acoustic function, head orientation to sound, reflex, blink, reflex, object fixation and pursuit, positive pupils reflex, lack of strabismus and nystagmus, sensory function, abdominal skin senses, complex toe movements to tactile foot stimulation, motor function, stable position, supine, beginning of reaching, symmetrical arm, leg movements with flexion, hand, mouth exploration, and free range of motion, fluent, complex, and generalized fidgety movements, head control in midline. Do you want to go on to this? 3-month hotspot developmental. The 3-month hotspot developmental, which was mentioned a bit earlier, related to brain maturation during first year of life seems to be continuously. But there seem to be two developmental hotspots: self-regulation, mimics and gesture-dependent tones to initiate friendly looking, reassurances when picked up, sleep-awake rhythm, curious for environment, attention, follows objects with interest, preferences, memory for the familiar and unfamiliar, cognition, looks consciously around, two different vocals, prosody and vocalization, more vocal bands spontaneously than reactive. Going on? Under segment 3, the question asked is, are there signs for etiology? Signs for etiology may be derived directly from neurological status, but accurate insight signs are not being addressed here. Number 1, chronic disturbances can be caused by sequelae of brain damage, like hypoxia, ischemic hemorrhagic insults. Number 2, congenital malformation of the brain. Number 3, encephalopathy due to viruses, bacteria, hormone dysfunction, autoimmune process, as well as metabolic disorders. Number 4, genetic or syndromal disorders, such as the Down syndrome. Number 5, neuromuscular diseases. Number 6, neurodegenerative diseases. Typical limits to these entities are a decline in head growth, central multisystem deficits, such as the eyes, deficits in acoustic function, head orientation and sound, reflex, blink, reflex, object fixation and pursuit, positive pupils reflex, lack of strabismus and nystagmus, sensory function, abdominal skin reflexes, complex toe movements to tactile foot stimulation, motor function, stable position, supine, beginning of reaching, symmetrical arm and leg movements with flexion, head, mouth exploration, free range of motion, fluent, complex and generalized fidgety movements, head control in the midline. Nystagmus, strabismus, blindness, hearing loss, motor floppiness with good reflexes, cortical seizures, and cognition. Motor function, stable position supine, beginning of reaching, symmetrical arm, leg movements with flexion, hand-mouth exploration, free range of motion, fluent, complex, and generalized fidgety movements, head control in the midline. At 9 months, we have self-regulation, interaction behavior, initiates and holds various eye contact. At 9 months, the infant is also shy to strangers, screens environment actively and normally. Children evaluated months or longer after leaving the hospital led to the prognosis of Mauricio. Speaking...
Okay. I think you can leave
Yep.
that.
Okay. There we go. Do you want this back?
Okay, now, as I had been to Pescara one time, they asked me to come back and give them a lecture on the preemie babies. Well, I said, there is no way in which I can give you a lecture on preemie babies because I don't have any opportunity to see these babies a period of time after they leave the hospital, because I saw them only during the hospitalized period. I had had in my practice 2 children who were very premature when I saw them. And so I'm going to tell you the story of one of these boys because he is such a fantastic demonstration of what can happen. Maurizio was a 23.5-week gestation. He was his mother's 5th pregnancy, and she was very unhappy. She was very disappointed to have this child because he seemed to be so extremely undeveloped. He couldn't use his hands. He wasn't focusing his vision. He couldn't eat, and he didn't seem to be particularly interested in anything that was going on around him. And as I say, Mother was terribly disappointed in this little boy. Well, when I saw him, I wondered, what could I expect to happen for this child? Now, that's the wrong question for a doctor to ask himself. What can I expect? Because we'll talk about the expectation aspect of this a little bit later. But anyhow, I took Maurizio into the treatment room, and he was observant. He was looking at all these new things that were to be seen. And he was cooperative. He was no problem. He wasn't complaining. And so I said, well, let us treat him once a week for a few months, and let's see what happens. And so we started treating him, addressing all of the structural problems, the cranial problems, the pelvic problems, and all of those areas that you would normally be thinking of when you're looking at a baby. And little by little, we found he was becoming more interested in the things going on. He was becoming more able to participate in whatever toys we had, in the music we had, and he was becoming a very happy little boy. He wasn't nearly as more or less depressed as he was when I first saw him. And so, let me give you a list of the problems that he had in addition to the prematurity. He had had 2 open heart surgeries for problems in the cardiac structure. He had had a cranial shunt for increased intracranial pressure. He had had 2 thoracic operations to open up his breathing apparatus. And he had had altogether about 6 or 8 surgical procedures. In other words, what had happened to him were not ideal for his progress. He was spastic. We couldn't dorsiflex his feet. We couldn't dorsiflex his hip joints. And his legs were constantly in a flexed position. His hands were constantly in a flexed position. And motion was very limited. Well, we started working with him, and little by little, we began to notice things were changing. The spasticity of the lower extremities was beginning to change from being a fixed flexion at the hips to being able to be moved into flexion. Yes, there was some resistance, but there was a degree of motion possible into flexion at the hips and the ankles. We had to be quite insistent that we began to get movement in his arms instead of having them always up here, lifted and in extension. Well, now that was quite a while ago, but now Maurizio is just after his 5th birthday. He is now in 1st grade in a regular class in school and is making remarkable progress. He's not fully able to walk yet, but if there is someone there to support him, one on each hand, he will make tremendous effort to walk. And in fact, he's looking forward to the fact that he is going to get a walker sometime quite soon. And it's very important to realize is that a child like this can either be committed to a wheelchair or some other piece of apparatus, which tends to mean that they're going to be in that path almost without deflection. And we find that school teachers are part of the problem. They want the child in a wheelchair, because if they're in a wheelchair, they don't require the same amount of assistance and support. But if you commit a child to a wheelchair, and that's what they see themselves doing, they tend to believe that that is the permanent status. And so that Maurizio is not committed to a wheelchair. He's going to be walking, I believe, in about another 6 months' time. Now, this is remarkable. Now he's 5 years of age, and he was a 24.5-week gestation. Now, after I had been the second time to Pescara, I said I wanted to see some of their babies that had been treated osteopathically, because I didn't feel that I was in any position to make a statement about what could be accomplished by treating these babies osteopathically unless I had an opportunity to see them. Well, the first little girl was 2.5 now. It was probably about 2 years since she'd had her osteopathic care. But she was a little one for her age. And the first thing Mother said to me was, well, she's not walking very well and she doesn't talk very well. You'll find that mothers always give you the most negative things they can to tell you initially. That's unfortunate. It should be a positive output rather than a negative one. Because this little girl ran into the treatment room. Yes, she was a little bit on her toes, but not very much. And she knew where the toy cupboard was. And she knew how to get the toys out of the toy cupboard. And so she was in her element. She knew how to control the environment far better than many children who had not had the limitations that she had. And so she was the first child I saw, which was certainly encouraging to what had been accomplished in her life following the osteopathic treatment. Well, now this was the time when there was a severe earthquake in a town not very far from Pescara, and almost every family had lost at least part of their home. One of the boys that I saw was about 9 years of age, and the description about him was that he had been quite severely shocked by the experience of being in the earthquake and of them losing their house as a result. So that is really understandable that he had gone through this very shocking experience in his life. However, there was an advantage to some people as a result of this earthquake, because the government had the many children of families in that village who now had lost their school. So the Italian government arranged for these children to go to the school in Pescara, which was a somewhat bigger school, a more challenging school, and so he had a better school experience than he would have had otherwise. But I'm not recommending we should have earthquakes on a regular basis. But those families were away from their home for almost a year. So that was a good opportunity to evaluate the progress that they were making. Now, the second child which I saw on that particular day was a boy who was, you might say, at the opposite end of the spectrum from Maurizio. This boy had been spastic, very limited in his movements, in his limbs. He was carried all the time. He did not have an independent transportation. And it was quite obvious that he had very little inherent function. But since he was there that day, he was treated. Now, I don't recommend to you the opportunity to treat 8 new patients in a day, especially when they're that age. But anyhow, we saw 8 of these children in that period of time. Now, although he had all of these limitations, after he had been treated, he was sitting on Mother's lap, looking around, interacting with the environment, and showing obvious progress. And all of those children who had been treated were showing distinct progress, certainly as a result of the treatment that they had had. Now, 8 patients isn't a big study, but I think it was a significant one under those circumstances. The treatment of very premature babies is one that is certainly not looked on with great approval in the United States. There are various reasons, one of which I think is involved with insurance. Insurance doesn't want to undertake those problems. They will cover children that are full-term babies, but they're very reluctant to handle those that are not full-term. And so that they don't get the opportunity that they might have. The other problem is that the insurance doesn't cover osteopathic care of children in the premature ward. That's another problem. It's not quite the same thing as evaluating their state of health, but at the same time, it is a very important one. Are we going to give these children the optimum ability to make progress, as with Maurizio? Or are we going to say, well, they're very limited, we can't expect much from them, and let it go at that, which is important. And so it comes to a very important question, that when you see a child like this, and mother says, well, what do you expect from my child? And there's only one answer to that question. I don't know. But do we ever know what any child is going to accomplish? We may have a greater or lesser expectation, but you don't really know exactly that you can say to mother, yes, he's going to do this in school, he's going to play soccer, and he's going to do all those other things. We can't say that, because there is an inherent therapeutic potency in every one of the children we see. And because that is what we are cooperating with, if we're working with that inherent therapeutic potency, we know that things are going to happen that will be a benefit, that will be progressive, and are going to enable this child to function at the optimum of his potential. And that, I think, is the summary of what I wanted to share with you about the importance of the care of the extremely premature babies. Let us not neglect the children because we don't know what the outcome will be. Okay.